and welcome to Dip or Not to Dip. This is a joint workshop between myself, I'm Elizabeth Beech, and Annie Joseph. And I have two jobs. I work in Bath and North East Somerset CCG, and this is a piece of work we've been doing in our health economy over the last 2 years. But I also work for NHS Improvement in the patient safety team as one of the national project leads for AMR and healthcare-acquired infections, and I do that 2 days a week. Annie works for Nottingham University Hospitals and has been working across the health economy in Nottingham. And if you tweet, you can see both our Twitter handles are up there. And if you need to contact us, we've also provided our email addresses. So to dip or not to dip is a patient-centred approach to manage UTIs in the care home environment. It's an evidence-based, systematic approach to how we diagnose and manage UTIs in residents in all of our nursing homes. And this is in Bath and North East Somerset. At the time when we started this piece of work, we didn't include residential homes. It was delivered by the CCG Care Home Pharmacy Service, working during 2015-16. And the reason we did this piece of work was that we had identified from looking at primary care GP prescribing some really high inappropriate use of broad-spectrum antibiotics. And it turns out that a large proportion of this was being driven by prescribing for nursing home residents. So local clinical audit in 2013 identified that residents were frequently prescribed antibiotics for a, quote, UTI, anywhere up to 1 in 2 residents in a nursing home environment. And the driver behind this was use of urine dipsticking to make that diagnosis. And then the care home would phone through to the GP, and the GP would release a prescription for the patient. In Bath and North East Somerset, we have a CCG enhanced service for our nursing home population. Hang on, I'm just going to wait for this lot to come in. Yes.
Can I ask why nurse homes and not care homes where you wouldn't have any nursing input? Because I would have thought that the problem is worse there.
Right, I'll come on to that in a minute.
Thank you.
Okay, right. We chose to look at nursing homes because that was where we had identified our highest prescribing, and we were going on. This was driven by high prescribing of antibiotics for UTI, and that was where we'd found our highest prescribing. So that was what initiated us to look at nursing homes. And we looked at nursing homes, not residential homes, because we had this model of a GP-enhanced service, and we had overlaid on that a care home pharmacy service. At the time we started this project, we were not providing any enhanced services to residential homes. Okay, so that was the reason for that. And we got some initial early small funding from the CCG to pay for the extra time involved for the care home pharmacists. Back to front a bit, what did early evaluation show? We actually showed a 56% reduction in the proportion of residents who had an antibiotic for a UTI. So in other words, we halved our antibiotic use, our inappropriate antibiotic use in our very frail elderly residents. And we initially evaluated this in 8 nursing homes, and then we went on to apply it to all 23 nursing homes, although only 22 took part. But you can see that 143 out of our whole nursing home population of 690 residents had at least one antibiotic for a UTI in the 6-month period after implementation. So this was starting to be, from a quality improvement point of view, our baseline data that we have gone on to work with ever since. We had a 67% reduction in the number of antibiotic prescriptions. And really interestingly, we took out nearly all of the prophylactic use of antibiotics. There was a question earlier in the morning presentation about management of recurrent UTI. I think that was to you, Annie. And Annie was suggesting looking at alternative approaches. And we took out a whole load of inappropriate use of antibiotics, of a variety of different antibiotics that were probably setting up patients for some really nice E. coli resistance. We were really concerned about unintended harm, and we're looking at the balancing looking at the consequences. So we were checking our hospital admissions for sepsis, and we were very surprised to find that actually our unplanned hospital admissions went down quite significantly. As with Annie's presentation earlier, using admissions data is always tricky because the coding is really variable. But we had absolutely no change in our residential home population over the same time period. We had no change in our in the admissions from our neighbouring CCG's population from both nursing homes and residential homes to the same acute provider that we share. And so the feeling was that this was the only explanation we had for this. So what did we actually do? Well, we used clever commissioning because obviously we are not the commissioners of social care provision, and we used a shadow sequin, and we used a shadow sequin for a whole bundle of improvements that we wanted the nursing homes to engage with, and that was very successful. I've mentioned we had a care home pharmacist team. They already existed, so we had existing relationships and structures, and we just needed some extra funding to give them some extra time to develop and deliver the intervention. The intervention we delivered was educational bundle, along with a change to documentation, and we took, we didn't take the dipsticks out. We asked them to stop using dipsticks, because obviously we can't take dipsticks out of care home environment because we have no right to do that. We used Sign 88 guidance to provide some structured documentation on a single A4 sheet of paper, which was very much symptomatic diagnosis. It drove the care home staff to assess the patient on clinical symptoms, fill that in, and then that was what was faxed through to the GP. So the GP for the first time was having some clinical patient information to make an informed decision with, rather than a positive dipstick doctor. And that we put very, very strong hydration messages at the beginning of the educational bundle. We included education around AMR, why it's a worry, and what the implications are for this particular health population if we were to continue to use inappropriate antibiotics. We communicated with everybody, as you always plan to, but we could clearly have done it better. It turned out the out-of-hours service wouldn't go out to our nursing home residents if they were called unless they'd had a urine dipstick, so we stopped that. We found that that nursing homes were unable to send a urine sample for culture to our lab because if it didn't have a dipstick, so we stopped that. And we did find there were a whole load of cans of worms that were unearthed. But it was very useful. We obviously worked very closely with the GPs aligned to the nursing home, so they were very much on board with this. And in fact, in the end, we had the GPs sending in complaints to our CCG complaint line, saying out of hours are still refusing to go and see somebody without a urine dipstick, and so on and so on. We have also shared this with our local ambulance service. So thinking back to some comments made earlier about the ambulance service from Linda Dempster, tend to get left out. We were monitoring for unintended harm. We knew we needed to do that right at the beginning, and we did include a pre- and post evaluation of 8 nursing homes, as well as taking a census approach. That's an example of the Sign 88 guidance. You're probably very familiar with it, and that's an example of the Public Health England guidance for diagnosis for UTI that was in use at the time. And we produced these on large laminated sheets to go up in the clinic rooms to remind staff. And interestingly, 2 years later, they're still there. Okay. I haven't got a copy of our data reporting form because we've got one that Annie's using that she's going to show later because it didn't like moving to the 1619 format. So this is I don't know how readable this is, but the slides will be shared afterwards. This is our data. So what we have, just to talk you through it, on the left-hand side in the very pale grey, we have the data from our 8 nursing homes that was pre-intervention, May to October 2013, and 6 months post-intervention, July to December 2015. And you can see there was a number of residents on the top row prescribed 1 or more courses of antibiotics for the management of acute UTI, then the number of antibiotics that were involved, and then the number of residents on the third row who had prophylactic antibiotic use. And you can see there, we put confidence intervals on it. I've even put p-values on it for the academics in the room. But you can see that was a very significant reduction in use of antibiotics And we have then continued to capture this data every 6 months. We've currently got a year's worth of data about to go on here, and we've now moved to 3 monthly census reporting. So we're treating it now as a quality improvement programme. We're going to set up run charts for our nursing homes so they can see how they're doing, and we're going to set up a run chart for our CCG nursing home dashboard. We always captured data about the number of catheter-associated UTIs, but we discovered very quickly on we had no idea what context that was in. And so in the January to June 2016 data capture period, we started collecting this data along the bottom, which was how many residents in that 6-month period had a catheter of any sort, for any reason. So 60 residents had a urinary catheter, and that's out of 700 residents. So that's what, about 8% of that population had a urinary catheter at some point during that time period, and 28 out of those 60, so that's nearly half, had at least one county. There were 45 counties and 28 residents. 26 residents with indwelling catheters had 1 or more acute courses of antibiotics for UTI. There were 41 courses, and there were 2 residents using ISC, which had 1 or more acute courses of antibiotics. Interestingly, 3 residents, and this is, remember, after we've implemented our improvement, 3 residents were prescribed antibiotic prophylaxis for UTI due to their indwelling catheter. So we gave them a catheter, and then we gave them some really naff low-dose antibiotics on top, just to really improve the quality of their care. Not great. But I have to say that the nursing home staff were really on the ball about trialling without catheter. They were very, very keen to avoid using catheters where possible, which was actually a really nice thing to discover. What we don't know, because that's the first time we've captured the data at that level, until we get through the next year's worth of data, is whether we've managed to improve that at all. But we're working with our bladder and bowel service, so hopefully if there's room for improvement, we will be able to do that. So what we're going to do next, well, we took the early data back to the CCG board. They said this is a no-brainer. This is now the day job for your care home pharmacists. They will need to continue to do this antimicrobial stewardship work in the nursing homes, and would you please roll it out to the residential homes? We are now starting to roll out to the residential homes. We've actually reviewed our educational bundle and our documentation, so a bit like a normal quality improvement program, we are continuing to look at how it's working and change stuff. But we've also now gone back out 2 years, 18 months later to re-educate that population, that workforce, with acute kidney injury, because Think Kidneys have produced some really fabulous resources for use in nursing home environment. Again, really strong emphasis on hydration. We obviously have communicated with everybody. We've continued to do that. We've now gone back into our acute provider hospital, who have said we'd like to do to dip or not to dip in the hospital. It's a bit of a no-brainer, really. It doesn't matter where you are. Using a urine dipstick to diagnose a UTI if you're over 65 is not a good idea. And we've shared the data very, very widely. We've shared it at conferences, at academic conferences. We've shared it at conferences like the NOLEX conferences. And that's been a really, really good thing to do, is to share the really early data, because we've had places like Nottingham who are going to share what they've been doing next, pick it up and improve it. We've had Cornwall who have been doing this with 2 IPC nurses called drug bug nurses. And we've now got a Vanguard site in Hertfordshire who's starting to do this. And from my point of view, I've now got access to other people's data because we've agreed to capture some core metrics. So now what we found in Bath and North East Somerset appears to be what other people are finding as well as baseline data, and they appear to be finding they can make a similar improvement. So suddenly that becomes really exciting because we're all using different implementation approaches. So it suggests that it's not a question of it only works in the Bath model, it's going to work in different ways. We're moving on to 3 monthly monitoring and producing a run chart. And we continue to apply quality improvement methodologies to this piece of work. Now, one really interesting thing is that this has been promoted to Jeremy Hunt at the launch of the gram-negative bacteremia reduction program at the RCN last year. To dip or not to dip has been promoted as one of the no-brainer interventions if you're looking to reduce your E. coli bacteremias. And that, from fingertips, is what the E. coli bacteremias look like for Bath and North East Somerset. And that downward trend was associated with when we started this quality improvement work. And we've not, as I said, been able to find any other explanation for it. I do wonder if it's the power of hydration, to be completely honest with you. I'm really a strong believer in hydration. But it's sort of useful to be able to link it up with some of the national reporting data. We've still got way to go. This is what our choice of antibiotic looks like. So our guidelines do not support the empirical use of trimethoprim in this particular patient population. So unless you know in the last 3 months you've had positive urine culture saying that your E. coli is sensitive to trimethoprim, you should not be using it. We're still using a shed load of trimethoprim. Okay, we're using half what we maybe used to use, but it's been really quite difficult to persuade the GPs to shift. Now, this is July to December 2015 data. I haven't presented the pie chart for the next 6 months' worth of data because it looks very similar. So we're struggling to get some change here. We have also introduced pivmecillinam in November 2015 into our guidelines. So I think we're going to start to see pivmecillinam as a drug of choice move into this. But the co-amoxiclav is really interesting because one of the other reasons we think our admissions may be reduced was we discovered all the co-amoxiclav before we started was deemed clinically inappropriate, and about half of the co-amoxiclav afterwards was deemed clinically appropriate. And we think probably GPs had been missing upper UTIs, and they'd been treating all UTIs on a positive dipstick as a lower UTI, and that maybe this had been resulting in some patients going on to be admitted. We've certainly seen more appropriate use, more appropriate management of our treatment of our UTIs. So we've taken out inappropriate antibiotic use, but we've increased appropriate antibiotic use, and that feels really good. Okay? So just to summarize the key messages from our health economy are that using evidence-based algorithm to diagnose UTI in our nursing home residents really has improved care. That we have delivered it within an educational bundle by care home pharmacists. That's the model we've chosen to use, and we're sticking with it. We have halved the number of residents receiving antibiotics for a UTI, and we've halved our use of antibiotics in those residents. We've taken out most of our prophylactic use of antibiotics, and we think we've improved the appropriate management of UTI. There's been a reduction in our unplanned admissions, and there's been some soft feedback. The GPs' practices have noticed, really noticeably, they are getting less of those afternoon calls from care homes panicking about patients. So it's made their lives easier, and they've said thank you. I put including hydration messages within the educational content because I think if we do nothing else, that's the single most useful thing we can do. And we've shared very, very widely. And look what Nottingham did.
Hello. Hi. So thanks, Elizabeth. My name's Annie Joseph. I came across Elizabeth and To Dip or Not to Dip just by chance, really. Someone had been to Sharing Success Day in Leeds, one of my community infection control colleagues, and she said, oh, I've heard this really great project and they're showing some really good results, and maybe you'd be interested in it. And I was just at the very start of a community fellowship where I was going to spend a whole year outside of my normal day job in the hospital as a microbiology registrar, looking at how we can improve working across the health economy, really working at the interface between secondary and primary care. I was looking for something really to get stuck into in the community, and To Dip or Not to Dip really caught my eye. And as a microbiologist, I hate urine dipsticks, so it was perfect for me. So as Elizabeth said, you have to... it's not, quality improvement is never something you can drag and drop. You know, it's worked in Bath, we'll do it Bath's way, we'll see how we can, you know, get it going in Nottingham. And Elizabeth said a couple of times, you know, it's a no-brainer. Well, the idea is a no-brainer, yes, but how to actually implement something that's quite complicated in terms of delivery locally was definitely caused me some brain ache. So we've taken a slightly different approach. We don't have care home pharmacists in some of our local CCGs, and most of our local CCGs are working towards an aligned service with GP practices, but aren't there yet. So there's only one of our local sort of 6 CCGs in the area I've been working in that has an aligned service. And on top of that, there was quite a lot of fragmentation of community care services. So continence services had kind of disappeared and come back, and there was lots of sort of recommissioning going on. It was quite a state of change, really. So how to improve things whilst personnel and structures, care structures are changing was one of my main challenges, really. So what did we do? Well, first of all, we wanted to start off like Elizabeth, assess our current practice, looking at diagnosis of UTIs in Nottinghamshire care homes. And we actually decided to just look at nursing and residential homes. A lot of the care homes locally were mixed, so it was going to be too difficult to try and pull out those two separate groups. And we felt that the improvement benefits were just as positive for residential residents, potentially. So we started off with all care residents. We managed to persuade, really, on goodwill, local clinical pharmacists within the CCGs who were very engaged in AMR, but had little time to commit to us, and very bravely sort of took on this task of doing the data searches and analysis. And we managed to collect a really good baseline data set for 12 months of what was currently going on. And it was really quite similar to the Bath data in terms of antibiotic usage. So that was reassuring in a way that we felt actually the potential to improve here. We're kind of at a similar baseline, so that was quite reassuring. In terms of the sort of the project management, I was taking the project lead role, but we were very lucky in that we managed to obtain some funding through public health and the local authority locally, who wanted to fund this as part of their sort of preventative and AMR sort of funding stream from an underspend. So we were really lucky that we managed to appoint Olu, who's sat over here, Olu Ogunbode. She's the project manager for To Dip or Not To Dip, and she's in post for 18 months in total. And really, it's a project initiation post, so it's not an ongoing thing, and we've always been thinking about sustainability of this approach from the very beginning, knowing that really we have probably 18 months, 2 years, to do everything that we can and hopefully embed this in a system that can go forward without full-time support from us. We've had some specialist input from local geriatricians who, like Elizabeth, are keen to take it back into the hospital in their role as well. And my role ultimately is sponsored by HEE, so clearly they've had a role to play as well. So we took what Elizabeth had done in terms of the educational resources and the assessment tools, and used that really to start initial conversations with GPs, geriatricians, nurses, care home managers, going in and getting their opinion, getting their feedback. How could this work locally, and how can we develop something that might be useful to you? And those initial conversations were really, really helpful, and we designed something that we hoped would work for us locally. And we're also measuring, hopefully, our impact moving forward. So we started, our pilot project started in January, is that right, this year? So we're kind of still in our initial phases. But to get to the point of starting the pilot project, I started in May 2016. So, there was probably a good 6 or 7 months of groundwork before we got to that point. Do you want to just skip on? Thanks. So this is just an overview, really, of where we are. So this was our core project team. And we were aiming to work with the 6 local CCGs in Mid and South Nottinghamshire. Nottingham West basically had the clinical pharmacist support to be able to get going with the data collection first of all. So we started the pilot there in January with 2 GP practices and 6 care homes in quite a tight geographical location in kind of a small town outside of Nottingham, which made things a little bit easier in terms of a controlled situation. And then not long after, in Mansfield and Ashfield, so north of the county, we started with 2 GP practices and 3 care homes, but they were very large care homes. And Nottingham North and East, we've just started a pilot in one of their 3 localities with 9 care homes there. Some of the other local CCGs was a lot of interest, a lot of, this sounds fantastic, can you do it for us? And the answer is always no, we can help you, but we can't do it for you. So I think there is a certain degree of effort and work and time involved in change, but I think all of the areas that have been involved have sort of fed back the benefit that they've had from it. So I don't think anyone's regretted being involved. Thanks. So in terms of our aims, really, we focused on an educational session, package and resource for care home staff. And we did GP visits as well. So for the GP practices that were involved, we did practice meeting visits with them to explain about the project, what potential benefits were, and also to feed back their data. So we had their baseline data, and we took their practice level data back to them and could compare it to their practice down the road and see how they were. And I think they found that quite useful. And when it's there on paper, you know, their inappropriate antibiotic use and how there was no clinical information documented in a large proportion of prescriptions, it was quite a powerful motivator for GPs to get on board. Plus the benefits of getting less calls from care homes was sort of a bit of an incentive as well. And we've also tried to promote the use of the boric acid red top bottles for urine samples. So they're the ones that can preserve the urine for a bit more in transit. What we were getting from our initial discussions with care home managers was that if it wasn't a weekday, Monday to Friday, in a morning when the resident had a suspected UTI, then no chance of getting a sample. They had no fridge storage facilities. Over a weekend, you might as well forget it. So they were really getting very few numbers of urine cultures to help guide treatment in these sort of older, more complex patients who are more likely to have resistant bugs. So we were promoting the use of those as well, which was quite new to a lot of the care homes. Yeah, so I've covered most of this. So a lot of meetings early on, so primary care pharmacists, trying to work out, coming from a secondary care background, trying to work out in our local setup within each CCG, who all did things differently, who does what, who actually performs what role, and which team they come under, and the cross-CCG working, everything. It took me a long time to get to grips with it. If you're already based in CCGs, you've got a big advantage in that you know who everybody is and how things work. I think we can probably skip on from that. So this was our assessment tool that we designed. We had a bit of feedback from care home staff, and we wanted to really take the Scottish Sign 88 guidance and put it into something that felt quite simple and workable for care home staff. So this is what we came up with, and they wanted really clear actions of what to do. And importantly, obviously, urine dipstick is not one of those things, but they wanted to have kind of who should we call and in which sort of scenario. And then on the reverse of the form, I've got some examples of this with us if you wanted to have a look after. The reverse of the form, we had some information about obtaining urine samples and residents with catheters. We were finding that there was a lot of confusion about people with catheters and being treated for suspected UTIs. Should you change the catheter? When should you do it? On antibiotics? How long? There was all sorts of things about, we've got a 2-day rule, but we've got a 3-day rule. And, you know, there's all these sorts of practices that become uncovered when you start to dig into a little bit more. So we helped to clarify that a little bit as well. I think that's about. So essentially, just to summarise our referral pathway, if care home staff suspected a possible UTI, they would fill in the form. And if it suggested, according to the SIGN guidance, that a UTI was likely or possible, then the standard procedure was that form would get faxed to the GP, and we'd had communication with the GP reception staff so that they knew what to do when this form arrived. And usually that went to the duty doctor for them to either decide to visit the resident, call the home back, find out a bit more information, and ultimately make that decision as whether to prescribe or not. The idea was that the forms would be sort of scanned in and kept in the patient's notes. I think our initial data suggests that probably isn't happening. The first process is happening in that they're getting it and making a decision from it, but they seem to just disappear into the ether, these forms, in the GP practice. So we're working on some templates within System 1 and EMIS to try and streamline that process, so actually the reception staff could put that information into it and put it as a task for the doctor so it's already there in the record, and just to improve that governance as well. Thanks. As part of the funding from the local authority, we had some money to invest in resources, which was really nice and not an opportunity that comes along very often. So we worked with a design company to think about our educational tools. We had been using a sort of a PowerPoint that I'd made myself, we'd worked together on, and it was working quite well, but we felt if we wanted to roll this out further, that kind of face-to-face training session, it's quite time intensive, and although it has additional benefits in terms of sort of interaction with care home staff, it was really going to limit us in terms of sustainability and wider rollout across our CCGs. So we've developed a training animation, which I'm hoping we can show sort of maybe 4 or 5 minutes of, just so you can see. And this, yeah, I'll do it in a second. But the training animation it's on YouTube through a secure link. So if anybody wants to use it, you're welcome to share and use as you want, basically, as long as you keep the acknowledgements for the funding at the end. So I'll just try and get this to work. In here? Oh, no, sorry, in this one. This one.
This training presentation introduces a care pathway for urinary tract infections, or UTIs, to dip or not to dip. The aim of this pathway is to improve the quality of care for older people living in care homes with suspected UTI. It focuses on how you, as care home professionals, can improve the diagnosis and the management of suspected UTIs, and can also help to prevent UTIs in your residence. Let's start with a quick quiz to get you thinking about UTIs. How much urine should the average adult produce in 24 hours?
You can do the quiz now. You should all know the answers.
The answer is 1.5 litres. Who is at greatest risk of a UTI? The answer is women. The answer to this is that women have a shorter urethra than men. The urethra is the tube that connects the bladder to the outside. This makes it easier for bacteria that live inside the bowel to get into the bladder. What time of year are UTIs more common? The answer is summer, and every year there is a summer peak of hospital admissions for the most severe type of UTI, bloodstream infections. What percentage of care home residents are prescribed an antibiotic for UTI in a 6-month period? The answer depends on the type of care home. There is wide variation in practice. The original To Dip or Not To Dip project team collected baseline data from 23 nursing homes in the southwest of England, and they found that up to 43% of residents there received an antibiotic for UTI. However, after introducing the To Dip or Not To Dip pathway, this was reduced to just 19%. This suggests there may be scope for reducing the amount of antibiotics prescribed to older people, and we will discuss why this might be beneficial. You may have guessed from the name that the To Dip or Not To Dip pathway relates to urine dipsticks, but first, let's recap what a UTI is. The urinary tract consists of the kidneys, which filter the blood and produce urine, the ureters, which are the tubes connecting the kidneys to the bladder where the urine is stored, and the urethra, which is the tube through which urine leaves the body. Bacteria normally live in the bowel and on the skin, but can enter the bladder by travelling up the urethra. In the bladder, they can grow and multiply and may cause symptoms of an infection, which are pain on passing urine, needing to pass urine more frequently or more urgently than usual, new incontinence or worse incontinence than normal, pain in the lower abdomen where the bladder is, or in the flanks where the kidneys are, shivering or chills, or a high or low temperature, and in older people they may become more confused or agitated than normal. Smelly or dark urine alone are not signs of a UTI, but may be signs of dehydration. Bacteria in the urine does not always mean an infection is present. In older people, bacteria can live harmlessly in the bladder without causing any problems. this is not an infection, as the bacteria are not causing harm to the person, and treating with antibiotics does not reduce future infections. In fact, antibiotics can be harmful and may lead to more infections in the future by disrupting the balance of the body's bacteria. So what proportion of older people living in care homes does this affect? Well, studies have shown approximately 40% of men, 50% of women, and 100% of people with indwelling catheters have bacteria in their urine without an infection being present. The urine dipstick will most likely be positive for nitrites, a chemical most bacteria make in the urine, and leukocyte esterase, which shows the presence of white blood cells. There may also be other markers, such as protein and glucose, which are unrelated to infection, but often present in older people. But none of these tell us whether or not there is actually a urinary tract infection. For this, a clinical assessment of signs and symptoms is needed, and the national best practice guidelines support this approach. But what's the harm in dipsticking? It is very difficult to ignore a positive result, even if it doesn't mean very much at all. It can be difficult to assess older people, for example if they are confused, and relying on the urine dipstick result in this setting may result in another diagnosis altogether being missed. It can also trigger antibiotics being prescribed. Antibiotics are powerful and precious drugs. Giving an older person antibiotics when they don't really need them can lead to side effects such as rashes, stomach upsets, or drug interactions. Clostridium difficile diarrhea, or C. diff, is a life-threatening infection of the bowel, and it is caused by antibiotics. You may have heard of antibiotic resistance. This happens when bacteria are exposed to antibiotics and then adapt so that they are no longer killed by the antibiotic. This means antibiotics won't work when the person really does need them. In fact, 1 in 3 older people will suffer side effects from antibiotics if given them inappropriately. So it is important to only use them when there is strong evidence of an infection. The to dip or not to dip pathway supports you as care home professionals to...
So I'll just pause it there. Obviously you can have a look at the full video on YouTube if you want to. The next couple of sections just take the care home staff through how to use the assessment tool, the referral pathway, and also some extra information on urine sampling. So ultimately, we're hoping that this can become sort of an online training package for homes, and we're hoping to use it in our care homes. There's a care homes training forum for Nottinghamshire that will kind of host these sorts of training resources along with other resources. What we did find quite effective actually was that care home managers wanted some evidence that they were doing this. They wanted certificates and documentation, and which is completely reasonable. So we provided all of that, and actually it was something we hadn't considered at all, but they really wanted. And we've actually had feedback recently from a care home manager who had a recent CQC inspection who said that they were really impressed and really showed that they were invested in quality in their home, and they were really impressed with it. So that was something we definitely sort of decided to develop locally, and we're going to continue with that. We have also had an e-learning package, so rather than just watching an animation, a kind of interactive e-learning package has been developed as well, and that's also freely available. One of our teaching fellows in geriatrics developed that, and that's on an open access platform, and we can share the information with you if you'd like. This is just to summarise our 2 pilot areas and the baseline data that we had. So for the first area, Nottingham West, we found that about 59% of residents were receiving at least 1 course of antibiotics for UTI in 12 months. The average number of treatment courses was about 2.4, and we actually found very low rates of UTI prophylaxis in our population. And I think part of that was in Nottingham West, pharmacists were already very engaged and had a bit of a blitz on prophylaxis, so we weren't surprised that it was so low when we found out that they'd kind of already gone in and done some targeted action on that. And in Mansfield and Ashfield, 74% of residents were receiving an antibiotic for UTI in 12 months. And actually in that CCG has overall higher prescribing rates, so it's kind of consistent with the picture there in general. and they had a bit higher use of prophylaxis, but not quite as high as Bath had. So just to summarise our initial baseline data and our initial sort of follow-up post-intervention. So we started in January, and we've just got through the first sort of 3 months post-intervention data. In Nottingham West, we found a 4% reduction in antibiotic residents prescribed an antibiotic, but a 44% relative reduction in overall antibiotic prescriptions. And what we did was, rather than comparing immediately the three months of data and then comparing another 3 months of data sort of consecutively within the year, we were a bit worried that we might have a high degree of seasonal variation. So we compared to the same time period the year before to try and account for that. Actually, in our baseline data, we seem to see a bit of a winter peak rather than a summer peak, which was interesting. The GPs fed back that might be to do with winter pressures and time constraints and just writing prescriptions because they were getting lots of calls. So it was difficult to know which way to go, really. But in Mansfield and Ashfield, we saw a bigger improvement. So it was only 3 care homes, but quite a lot of residents, and they went from having 38% of residents receiving an antibiotic down to 8%. So a 30% absolute reduction in the number of their residents that had an antibiotic, and a 71% relative reduction in their antibiotic prescriptions. And prophylaxis, again, they had a few residents on in general in that time period anyway. So I think we're starting to see some positive results. It's a work in progress. We've just got small pilot areas working first of all, but we're working on the sort of the wider rollout in both of these areas alongside this. So our admissions data, we started in January, which is here. What we were really wanting to use admissions data for was as a balancing measure, just to make sure that what we're doing wasn't causing unintended harm, rather than using it as a sort of a measure of quality. So I think there's so many different things happening in care homes, I would be quite cautious about that. But what we found, the top blue line is all emergency admissions from care homes in the CCG. The green line is all admissions that had somewhere in that coding a UTI or acute kidney injury. And then the red one at the bottom, much smaller numbers, but there were admissions that had a primary diagnosis of UTI on admission. So we wanted to make sure we were capturing all the nuances of coding, essentially. But what we found is that it looks like from January, when we introduced the pilot, there hasn't been a rise in admissions. And if anything, it looks like things are going in a kind of a nicer trend. So that was reassuring. And similarly with the other pilot area as well, we've seen a kind of trend in the right direction, so reassuring from the admissions front. Dipstick testing significantly reduced. The care home staff were really, really engaged, and I was sort of quite impressed and sort of surprised, nicely surprised in a lot of ways that they really wanted training. They were really engaged in training. And, you know, some sessions they would have literally everybody coming in on their off days, and the night workers would be in and to come for a training session in the afternoon. So the care home staff were really engaged. Some care home managers were a little bit more tricky to crack, I think. And that probably reflected a lot of other things going on in the care home as well, new management, turnover, all of those sorts of issues. But in the main, there was really positive response from the care home sector in general. Yes, I've just mentioned that about the care home staff. High turnover is definitely an issue, and that was why we tried to sort of move towards perhaps less face-to-face training sessions by developing the e-learning package, the animation, the resources, so that we sort of tried to pitch it to the care home staff. Actually, you could use the DVD of the animation and the e-learning package for your new starters so that they can get trained up on how you use the care pathway here. You can have that certificate printed so you can show that all of your new staff have got their training and what you're doing locally. So that's the approach we're kind of trying to take forward in the other areas that we're moving out to. The project was not incentivised at all for care homes or GPs or CCGs, which has always been a challenge along the way. We did have other resources, luckily, through the local authority for educational resources and for a project manager, but there was no direct incentivisation. So I think there's a lot of goodwill out there, and I think we had tried to find ways that to engage the CCGs and show what was in it for them in terms of lots of them were wanting to reduce their antibiotic use. They had that as some of their key performance indicators. The quality premium may be a little bit of a lever, maybe not. And I've just lost my train of thought. Yeah, I can't remember what I was going to say. What were you, do you want to say anything, Ali? Oh, yeah, and then about the sustainability of the project. So we're hoping that we'll be at a point where we've got the resources and the local care providers trained to deliver themselves. So we've been working with the community matrons a lot, and they've been just absolutely vital, just took the project and ran with it and loved it, and have been trying to share it with all the district nurses, and you know, they've been real champions, early champions of it, which has been fantastic. So really to try and embed it within the fragmented, but their healthcare providers in the community. So if you're interested and you're into sort of apps and things like that, there's an app called Slack, and there's a community of interest called To Dip or Not To Dip. If you would like to join, there's all sorts of different sort of channels of activity. So there's sort of general talk about UTIs, to dip or not to dip. Everybody who's starting to take this approach around the country is sharing what they're doing. You can access all the resources that we've shown on there, and generally sort of get involved and pick people's brains on how something like this could possibly work for you locally.